Good morning. Thank you so much for talking with me about your QuickShot. My name is Stephanie Savage, and I'm a professor of surgery at the University of Wisconsin. And today I'm talking with Dr. Mike Wandling, who is at Houston, who's going to be discussing his QuickShot on multi-center validation of the bowel injury prediction score for identifying patients requiring surgery. So welcome, and thank you for talking with us.
Thank you for talking with me.
So tell me a little bit about what the motivation was, or what gave you the idea to do this particular study.
So this was all born, probably between 5 and 10 years ago at our center, where we see a lot of kind of high energy blunt trauma patients. And the big question is, how do you figure out which ones of these patients need to go to the operating room for blunt bowel and mesenteric injury? You'll have a low grade spleen, but what do you do with these things in the mesentery? And sort of how do you decide which ones are at a higher risk for having an actual bowel injury that will require something, since some of the CT findings can be a little more subtle. So at that time, Dr. Michelle McNutt, our trauma medical director now, did a retrospective analysis of our institutional data and basically looked through a whole variety of factors and realized that the independent predictors for bowel injury or blunt bowel and mesenteric injury were CT. So we had to develop a CT grading system. So a CT grade greater than 4, which is basically bowel wall thickening in the presence of interloop free fluid, or greater, so contrast extravasation from either the bowel or the mesenteric vessels, were independently predictive. A white blood cell count greater than 17,000 was predictive. That was 17,000 was just what ended up from our single center institutional data shaking out as being independently predictive, and then abdominal tenderness on exam. At the time, we're pretty surprised that things like seatbelt sign or other factors that you might typically associate with these injuries would be predictive, and found that they weren't. So use that institutional data from Houston to come up with this score and show that it was actually pretty successful. And from that, it was presented and published in the Journal of Trauma. And one of the big next steps is, let's validate this with a multi-center trial, which is kind of where this project was born.
So I was interested in the categories that you chose because, for example, the white blood cell count of the leukocytosis, it seems like every trauma patient has a leukocytosis. So was this something that was specific to isolated bowel injuries when you did the initial study, or did you find that it was multiple kinds of injuries, and can you really identify the leukocytosis specifically related to the bowels, or is it just the general trauma and the fact that they have a spleen injury and a pulmonary contusion? How do you sort that piece out?
Yeah, so it's hard to piece out kind of specifically with respect to that, and that's why it's a multi-factor scoring system. White blood cell count greater than 17,000, so sure, a lot of people have a reactive leukocytosis, but when you add the additional factors in, it strengthens it considerably. The white blood cell count is nice to use because it's sort of readily available within the first 30 to 60 minutes of a patient hitting the door. So it's a objective marker that can be useful. So are there people that have a white blood cell count of 20,000 that don't have bowel injury? Absolutely. But when taken in the context of a concerning CT scan and abdominal pain, that strengthens the sensitivity and specificity of that value in particular.
So in your abstract, you talk about 38% of the patients required operative intervention for a bowel injury, which seems like a pretty high number. How did you select the patients that were included in the study?
So at the individual sites, all patients above the age of 16 who had high energy mechanisms of injury, so car crashes, motorcycle crashes, autopeds, they were all screened for CT findings of blunt bowel or mesenteric injury. And that could range from a mesenteric contusion all the way to oral contrast extravasation or rectal contrast extravasation. So all patients with some degree of blunt bowel or mesenteric injury were identified after screening all blunt trauma patients with that met the high energy mechanism, and then from there they received their institutional standard of care, and retrospectively went back and saw which ones of these people actually required a laparotomy, and of those, which ones actually required an intervention during that laparotomy, specifically related to the injuries identified.
So how would you propose I use this in my practice?
So we use it very routinely by looking at folks that come in with a concerning mechanism of injury. And, it's not that uncommon that you have some free fluid. And in the setting of a liver or a splenic injury, what do you kind of do with that fluid? Is that from the spleen or is that from something else? So taking those CT findings and mechanistic findings in the context of their white count that comes back in their physical exam, at a minimum, thinking about, if you're screening positive or have a BIP score greater than 2, maybe we should be taking these patients to the operating room early for diagnostic laparoscopy, particularly in the setting of, altered mentation, which, a large number of these folks have, whether due to intoxication or mild or severe traumatic brain injury. So really using it and kind of saying, okay, I have this CAT scan, but now let's look at this. If their white count's 20,000, maybe I should have a little lower threshold to go take these people and put a scope in and make sure they don't have something else.
Okay. Well, I mean, it's a multi-center study, so takes a lot of work, a lot of wrangling. Where do you go from here with the research related to the blunt injury prediction score?
Yeah, so I think moving forward, I think it's really going to be starting to apply this and maybe start to apply this prospectively and actually looking at, how are we using this? And how effective is it in actually aiding and facilitating the early identification of these injuries? So I think it's, about time that we start reaching out to the participating centers and see if we should start looking at this more prospectively in terms of utilization. It'd be great to ultimately randomize people into utilization of the scoring or not. Whether or not that will be feasible is kind of to be determined. But I think moving forward, actually using this prospectively, getting feedback and actually assessing its performance in that capacity would be important.
Great. Well, I wish you guys the best of luck with your research. It's a really nice abstract and really nice research, and we look forward to hearing it.
Awesome. Well, thank you very much. I'm looking forward to talking about it on Friday.
Great. Bye-bye.
Bye.